It really is a national issue with local impact. All states have a growing older population, but only 38 states have MSW programs with an aging concentration, and only 45% of MSW programs nationally offer an aging concentration. So this is, again, very critical when we're thinking about the workforce and the demand. So how do we solve it? Really, a clear path for geriatric social work is about coordination across the medical and social models, between care settings, and among care providers. We have a service that we've been providing where I work full-time at Rush University Medical Center in Chicago, where social workers are really becoming the transitional coordinators from hospital to home, helping people not fall through the cracks, making sure their needs are met, and also reducing 30-day readmission. Those are very important roles. Integrating into standard service delivery in a variety of settings is also very important. Incentivizing job creation around programs that are, it's not just enough to train people in geriatric social work, but they need to have models that are interesting models in which they can work, where they get reimbursed for that work at a decent wage. And we need to collaborate with other disciplines. It's all about the team in terms of caring for older adults. We need to work with universities, academic institutions, stimulate the idea of social work and geriatric social work earlier. We need to work with professional associations, just like we're doing among the EWA, because I think together we have a stronger impact in terms of the workforce issues. We need to expose students early. Very often you talk to people at a dinner party or wherever and they'll say, "You work with older adults? How can you do that? Isn't it depressing?" Well, that's the image that people have, and how do we demystify that image? Well, part of it is getting them connected at an early age with older adults to reduce the myths, to reduce the stigma, and the likelihood of them specializing in aging. Another big piece is to have folks in academic settings who are the Pied Piper of aging work, and I think that that has helped in social work through a lot of the Hartford-sponsored geriatric social work initiatives. Again, fiscal incentives, educational strategies to recruit students early, dealing with loan debt, and we'll talk about that more later. And the whole notion of respecialization, I think it's really important to catch students early, but I also know that people, once they've graduated or further along, at least in social work, all of a sudden wake up someday and they say, "Oh my patients and clients around me are older. Maybe I should learn something about working with older adults." So I think there's potential there too. So we need to incorporate geriatric social work into the new models that we're talking about around self-management, disease prevention, health promotion. We have made a difference. We can make a difference. Care coordination, transitional care, the whole promising new roles in patient-centered medical homes and accountable care organizations are going to be critical, community-based teams. Again, sometimes when we're talking with people with the Innovation Center, at CMS, et cetera, when they think of team, very often it's the physician and the nurse. They're not thinking about it a little more broadly. So it's incumbent upon us to really advance that. And we've shown an increase in appropriate utilization, a decrease in readmission, improved health outcomes, and higher patient satisfaction. We, again, need to ensure those reimbursable roles to incentivize geriatric assessment, patient navigation, care coordination, and the teams, trying to find ways to pay for that critical care and build new incentives for that. For example, social workers have on the books been able to bill for this area called health and behavior codes, which are non-mental health codes. That means if someone's struggling with an adjustment to an illness, they could work with that person in a counseling relationship and hopefully bill for that. But that's happening in maybe 2 states in the country because most Medicare fiscal intermediaries are preventing that billing from occurring because of their lack of understanding of what social work does. So that's really important that we try to look at some of those barriers that are getting in the way of helping older adults and their families, and that we need to continue to test and replicate evidence-based geriatric social work models that bridge the medical and social worlds of care. And then what will happen if we solve it? We'll reduce some of the Medicare and Medicaid costs that we're so struggling to reduce in terms of the bending the cost curve, and to make sure older adults are linked to long-term care supports and home and community-based services, staying out of hospitals and nursing homes unnecessarily, reducing healthcare utilization, and also reducing some of the family caregiver burden and improving caregiver health. And then as a result, we'll have a better quality of life for older adults and caregivers with our more person-centered approach, and be able to address them with knowledge and compassion that I think is a big part of what all of us bring, but particularly social work in their person-centered approach and looking at people in the environment. Thank you for letting me be here today, and I appreciate it, and look forward to questions and answers at the end. Thank you.